Good afternoon, and thank you for joining us for the next event in LHSN's Safer Care Accelerator webinar series.
We're thrilled to be joined by Professor Sir Liam Donaldson. I know in the world of patient safety, he requires no introduction, but I will do a very brief one. He's obviously recognized as an international champion of patient safety and public health, was the foundation chair of the WHO World Alliance for Patient Safety, is WHO's envoy for patient safety, currently the chair of health policy at Imperial College, and also the chancellor of Newcastle University. So without further ado, I'd like to go ahead and hand it over to Sir Liam.
Hello, everybody. Thank you for joining us today. What I'd like to do is make some reflections on patient safety, where the journey started, where we've got to, how much has changed since perhaps the year 2000, when I believe that things really started to take off, something about the programs that the World Health Organization has been running and what we can learn from those, and maybe just to highlight one or two areas where I think things could improve a lot if we paid more attention to them. So these are reflective comments. I would not have any firm answers necessarily on some of them, but I hope they'll stimulate you to think about the areas that I'm going to highlight, and also might provoke some comment and discussion. And we have a relatively short time for the presentation, and then we'll be moving into discussion. So there isn't the opportunity to perhaps go exhaustively over everything, so I hope you'll forgive me if at times I'm summarizing what are quite complex and big subjects. We're broadcasting here from St Mary's Hospital in Paddington, London. Some of you will know it. It's very near Paddington Railway Station, which is one of the big railway hubs in the United Kingdom. I was walking past there last week, looking at some construction work that was going on, and I saw this sign: "All harm is preventable." Now, you will know that within healthcare, when anybody tries to say all harm is preventable, or all serious harm is preventable even, it provokes a lot of cynicism and sometimes laughter. But yet here we have a sister industry, perhaps not as complex as healthcare, which is clearly nailing its colors to the mast in a visible way that everybody can see, and demonstrating accountability. So that's just a casual observation for me as I was walking by, and thought maybe it might be a good place to start contrasting, as I'm going to do at various points in the presentation, healthcare with other industries. Now here is another industry. See if you can guess what it is. It was established in 1890. It's highly decentralized, so the opportunity to control quality is much reduced by the decentralization. It's an unpredictable, challenging environment. The workforce delivering care is poorly educated. It's a big business, 260,000 transactions per day, 6 days of the week, 52 weeks a year. And at least until recently, there has been no IT to back up that service. Sounds quite impressive? Well, this is the Dabbawalas of Mumbai, India. Some of you may have read about them. They deliver hot meals to their customers. They pick them up from the customer's home where they've cooked them. They load them onto wagons, and then they go down to usually the railway station, and they're then delivered to the person's office, sometimes to schools. Their empty tin is then collected and delivered back to the home. There are mainly a male workforce who delivers 175,000 lunches called tiffin every day in Mumbai, the business capital of India. Their error rate, they make one mistake every 2 months. That means there's one error in every 16 million transactions, and that's a 6 Sigma level of performance. So that's one industry which seems very much like a cottage industry that manages to maintain the highest standards of reliability that you would see anywhere. You may think it's simple, but anybody who's been to Mumbai and sees these tiffin boxes flying around, color-coded in a way that all their workforce know, will say, well, it's a complex system. You'd think it would be more prone to error than that. 1 in 16 million. Here's another industry. See if you can guess what this is. It's a mixture of centralized and devolved, operates in an unpredictable, challenging environment, a highly educated workforce in contrast to the Dabbawalas, hundreds of thousands of transactions per day, 7 days a week, 52 days per year, extensive information technology. Of course, it's healthcare. And the rate of error in healthcare, as shown from many studies carried out in the early 2000s, late 1990s, runs at a rate of something like 1 in 10 hospital admissions. So no 1 in 16 million there. And maybe we can forgive healthcare to a certain extent because it is a more complex environment, a more complex industry. But nevertheless, not a precise benchmark, but an illustrative comparison between performance and resilience and standard setting and reliability in two different industries. But the story of healthcare safety dates is often tied back to two reports that were produced in the year 2000 or thereabouts. The Institute of Medicine's report, To Err is Human, which made the shocking comparison between the number of hospital deaths, comparing them to people lost in crashes in jumbo jets, horrified the American public, American politicians, and still widely quoted to this day. And my own report, when I was Chief Medical Officer in the United Kingdom, was called An Organisation with a Memory, which scoped the question of safety in the same sort of way and set out some challenges for the National Health Service. I saw my first case of unsafe care in 1987 when I was in charge of the health service in a region of England and started to look at cases then. Wasn't called patient safety in those days, but I've thought and reflected a lot on the subject over the years since. So when we look back to that time at the beginning of the 21st century, when safety was not really talked about a great deal and was beginning to be profiled in those reports and in some of the studies of the prevalence of adverse events and harm, I think this slide would summarize the state of play. Generally speaking, safety was the domain of academics and enthusiasts. There was a wider disinterest within the healthcare community, healthcare leadership. When I show this slide to audiences around the world, a lot of people say that particular aspect has not changed much, that in many places, safety is still the passion of a small proportion of people and not those people who can do most to affect the safety of care. The scale of the problem was recognized, so there was a degree of ignorance. People were not aware until those reports came out of the scale of harm. And generally, incidents were seen as something that happened locally, parochial events, which not much could be learned from more widely. Just an investigation locally and maybe a few recommendations to follow up, but no connection between different events happening in different places. That was the way things were looked at the beginning of the 21st century. And I think also a view that people looked across from their institutions, their hospitals, and said, well, those bad people, we can understand why something terrible happened there, but it couldn't happen to us. So generally, the philosophy that's predominant in all other safety-conscious industries, that we should be constantly aware that the worst could always happen here and we've got to prevent it. That was not the prevailing attitude within healthcare. And generally, information was victims, families, patients who were harmed, and families who were the relative of somebody who had died were treated appallingly. And I've talked to many victims of harm around the world, and this idea that you should keep them at arm's length and not keep them informed and often treat them badly, the secondary damage caused by harm, by the way the victims are treated, is a very big feature, in my view, of safety. Even today, it has improved, but certainly it was there very heavily at the beginning. So what are some of the things that healthcare could do differently? Well, one thing that's done a lot in other industries is standardization. Generally speaking, this is an anathema to the medical profession, my profession. I once talked about this at a conference 5 or 6 years ago, and a very angry surgeon got up and said, if you want us to do these operations in the same way, we might as well go and work in factories. So that we are brought into the world as a medical profession when we're students and become junior doctors, believing that autonomous practice is the essence of what we are. Now, of course, I'm exaggerating slightly. Many people do take the importance of standardizing their approach, certainly following best practice guidelines. But on the other hand, in the area of risk as opposed to effectiveness of care, standardization is less frequently adopted, and yet we know again from other industries how successful that should be. Why should we worry? Well, here's a couple of examples that do illustrate why we should worry. This, not so long ago, happened in one of the most prestigious hospitals in the United Kingdom, the Adam Brooks Hospital in Cambridge. And in only a 6-week period, there were these incidents in surgery which relate to procedures which should be very, very basic, being completely flawed and faulty. So a retained swab in one patient, a retained instrument in another, the wrong side to the body being operated on in week 4, and then the wrong implant being placed into a patient's hips or in week 6. And the comment to the media of the medical director, and I don't criticize this, but I do say it's typical of the sort of comment that is made after incidents like this. He said, 100% should be our standard for patient safety. These largely preventable incidents should never happen if the right measures are in place. Now, as I say, I don't criticize the individual, but that sort of comment is symbolic, I think, of the view that is often expressed. Yes, safety is our business, safety is our priority, these things shouldn't happen. What can't and isn't ever said is, this will never happen again. Now, that's probably impossible to guarantee, but what maybe people should say more often is, we can't guarantee this would never happen, but we're going to make it an absolute rarity. I've never heard that said. And then if we look across the Atlantic to Rhode Island Hospital, affiliated to an Ivy League university, Brown, in 1 year, we saw these surgical errors in just one department. And there are 59 specialties of medicine and surgery, and neurosurgery is only one of the 59. Yet in that single specialty, we saw in that period of time 3 serious errors. One operation went awry after an experienced brain surgeon insisted to a nurse that he knew what side of the head to operate on. Another time, a doctor in training cut into the wrong side of a patient's head after skipping the preoperative checklist. And in a third case, the chief resident started brain surgery in the wrong place. The nurse realized that he was operating in the wrong place, but felt powerless to intervene and stop him. A question there about hierarchies, but that's perhaps a story for another day. So when I was the Chief Medical Officer in the United Kingdom, I also representative of the UK on the World Health Organization. And at that time, I used my status as a country representative to propose a resolution to start a program of patient safety at global level. And this led to the World Alliance for Patient Safety, which I chaired. And I just want to mention a couple of things about the programs that the WHO continues to this day, and my role's slightly changed now, but it's still a program that's running. But before I do, the examples that are in the world's literature on patient safety, the published literature, are nearly all about high-income countries, and they're nearly all about hospitals. But if you look out into low-income countries, about which much less data are available, you do see a different pattern, but you do see similarities. And this is all my examples are in the public domain, and this was actually published by Time magazine and the subject of a documentary, but it was about a young woman called Mama Sese, who was 18 years old, and she lived in Sierra Leone. She was pregnant for the second time, and she was on her way to hospital for delivery, traveling to the hospital, but it wasn't realized that she had twins and that the second twin was being delivered. The midwives hadn't noticed and they weren't prepared. And when she started bleeding after delivery of what they thought was the first and only baby, the nurses ran to find the doctor, who was also unaware that the woman was expecting twins. It took them an hour to collect blood units from the blood bank and get the doctor. The nurses were not aware that they could have started uterine compression, nor did they look for medication that could help, like oxytocin. And just as the doctor arrived an hour later to put in a transfusion line, this poor young woman died. And she would not be atypical of many women who die in similar circumstances in low-income countries. And if we use James Reason's Swiss cheese to look at why this happened, then clearly you would expect any patient anywhere in the world to be protected. And some of the things that would protect them would be the presence of skilled staff, essential equipment, clear policies and protocols, and in this field, particularly of obstetrics and maternity care, a risk management plan. Those are just some of the defenses, and obviously in low-income settings, it's not possible to be as strong and firm on these things as it is in a high-income country. But when there are gaps or holes in the Swiss cheese, in this case, staff with inadequate knowledge, monitoring unavailable, the interventions were ill-defined, and there was very poor handling of the emergency, then it's almost inevitable that the patient is heading for a catastrophic outcome. And one of the interests, I think, in the work that's been done on patient safety in low-income countries is the extent to which low-technology interventions can be helpful, the uterine compression, the availability of oxytocin. And this is a very nice piece of work done by the USAID project. It's called the Healthcare Improvement Project. And we think of healthcare improvement as something, again, which happens in high-income countries, and techniques are applied to hospital infection and catheter-associated infection and so forth. But this is a very nice example of how exactly the same techniques of improvement science used in a low-income environment can address something like postpartum hemorrhage. And here, a bundle, the AMTSL, those letters stand for the active management of the third stage of labor, active AMTSL, active management of the third stage of labor, in Niger. And the program used quality improvement techniques, collaborative methods, getting people together, looking at best practice, standardizing approaches. And you can see there, the red line, the blue line shows the coverage of the bundle of care going up, and the postpartum hemorrhage rate, which is a very lethal complication, as I showed you in the last case, going down. So when we started off the World Alliance for Patient Safety, we set two global challenges. The second of them was the Safe Surgery challenge, and we asked Atul Gandhi to lead that, and he did an excellent job working with surgeons around the world and produced a surgical checklist, very much akin to the sort of checklists that are used in the airline industry. And I won't bother you with the data, but the data are pretty convincing that complications and mortality is reduced significantly from the use of the checklist, and this was the editorial in the New England Journal of Medicine after one of the studies. Of course, checklists are not the final step towards optimizing surgical quality, but in the meantime, they seem to have crossed the threshold from good idea to standard of care. And they are now widely used around the world. But what about the culture in which they operate? Well, to do a major operation, some years ago I was in an airline, an airport, and I tore this out of a magazine, so I can't source it for you. But it's a picture of all the people involved in a cardiothoracic bypass operation. Look at them all. And these people have all got to work together. All of them have got to work together as a cohesive whole. Yet if we were going to caricature our approach to professional education around the world, I think our caricature slogan would be, educate in silos, practice in teams. So we are a team-based endeavor, as this shows, but then we choose to educate our professional groups separately. That's got to change. But is the checklist alive and well? In most cases it is. But at the anecdotal level, we hear not just from one country, but around the world, small examples, small numbers of cases where those that we're relying on to deliver the checklist to keep the patient safe are rebelling against its use. A surgeon in one country saying that he thinks the checklist is childish and won't do it. A surgeon in another country filling out the checklists for all the patients on his list in advance of the operations actually taking place. And not taking the checklist seriously is a reflection of the safety culture of an organization. And so at some point, I think, in the evolution of a practice that is life-saving, there needs to be a personal accountability for people that refuse to use it. How would we feel if the aircraft we were flying in, the surgeon, the pilot announced before takeoff that he was rather bored with the checklist and wasn't going to do it and would just take off without bothering? We would be scrambling to get off the plane, I'm sure. So there's the checklist. It's a proper team, even though you know people. And there is a bit of science as well in it, because I was talking to a sociology researcher some time ago about hierarchies. And she said, interestingly, the evidence shows that if you speak up once as a junior person, you are more likely to feel empowered to speak again. So even the simple act of introducing yourself, even to people that have known you for many years, will be a permission for you in your own mind to speak up if something bad were to happen. The first challenge actually came before the surgical one, was clean care is safer care. We launched around the world a challenge to health ministers in front of their media to sign up to a program of giving priority to healthcare infection and making themselves accountability. The flagship element of the program was hand hygiene. That was the position when we started. The orange-colored were the places that had agreed to sign up. And then eventually, this is the degree of coverage that we achieved. It's a soft indicator. It's not a hard-nosed evaluation of the amount of infection going down, but nevertheless, I think an impressive engagement exercise, an awareness-raising exercise. The idea of the alcohol hand rub, it was expensive and unaffordable in some of the low-income countries, but the WHO facilitated local manufacture, so it was cheap and readily available, because many of the hospitals we saw in low-income settings did not have accessible clean water to wash with. So the alcohol rubs was quite genuinely not only a substitute for that, but a lifesaver as well. And then standardizing practice to the 5 moments, which were developed by Professor Didier Piquet and his colleagues at Geneva Hospital, has also proved a very valuable tool. WHO's done other things. We've set up, with the help of our Australian colleagues, a patient safety curriculum, both for medical students and now for all health professions. And this is being implemented in some parts of the world, and a very, very valuable way of creating an idea of clinical practice which goes beyond just simply treating the patient in front of you and widens the paradigm to considering the safety and quality of the service that you're delivering, not just that one patient. And then on to other people that we've worked with. We've worked with Peter Pronovost, one of the outstanding safety leaders in the world, and his program, which you'll be very familiar with, of standardizing to a bundle of care for reducing catheter-associated bloodstream infection. I make another point with this slide, which is very interesting. Some people think that the intervention, in this case the bundle of care practices, is the key measure. It is. But there is a separate side of it, which is the implementation of the measure. And the intervention and the implementation are 2 separate things. And what Dr. Pronovost and his team have found as they've done this with the WHO in other parts of the world is, it's no good just telling people what the bundle is and expecting them to adopt it. You have to do organizational and people development to change the culture alongside the intervention. So you make the intervention known and available, but you also encourage its adoption. So intervention and implementation. And in my long experience in healthcare policy and management, implementation is done very badly and is often fails to implement a clear intervention that would work, because management does not know how to bring about change, especially whenever there's professional resistance. Culture has many strands. We know about the blame culture, but we've talked a little bit about hierarchy. But when people talk about a patient safety culture, it often sounds very vague. But I think it's much more helpful to look at the strands. For example, unless you have good data and give it to the clinicians to use in the front line, then it's much more difficult to improve safety. Coming to the final few slides now. In my country, we developed an incident reporting system. We call it the National Reporting and Learning System, to receive reports, analyze them, and try and work out what goes wrong. We now have accumulated database of 11 million incidents. The difficulty has been the logistics of getting meaningful learning out of it, and it's something that is both a success in encouraging these levels of reports, but a weakness that we don't yet have the key to successful learning. And yet, the incidents are building up. There's a pyramid, and we probably learn less from the no and low harm incidents than we actually should. So finally, if we look back to the beginning of the 21st century, what have been the disappointments? Well, I think we've we've shown relatively few concrete examples of where we've learned from things that have gone wrong and reduced the risk of things happening in the future, which is the simple principle that reporting is based on in other industries. A limited range evidence base of effective solutions, and despite what happens in the places that are leading edge and enthusiastic, it's always important in healthcare to look at the middle ground, not to look at the academic centres and the place where all the enthusiasts are, but look at the middle ground of hospitals. And I think there we can still confidently say that the degree of engagement and interest of frontline practitioners in patient safety isn't quite there. Patients are not as involved as heavily as they should be, and generally speaking, people are not aware of the relatively high risks compared to other industries that are prevalent in healthcare. But we have seen progress. There's now a good understanding of the role of systems and the Swiss cheese. We know that we're dealing with a big problem, so the challenge is there. There's a much greater awareness of the role of so-called human factors in accident causation in healthcare. We have some successful campaigns, such as the WHO's campaigns, Dr. Pronobos's work, and one or two others. And then, importantly, although it's quite a narrow area, a very successful area of risk reduction, improving the competence of individuals and teams by the use of simulation. So that's all I had to say initially, and I'd like to thank you for listening.
Well, thank you so much for that. And we'd like to go ahead at this point to open it up to the floor for questions. Just to start, I had a question. Given the extremely wide scope of patient safety, what would you say to a healthcare leader, a clinician, a nurse, an administrator who's basically just feeling overwhelmed? Where should they start?
I think they should start by looking at places which have a good record on patient safety and have fully engaged their staff, and see what can be learned from somewhere that's doing it well. Make a visit there and be reassured that if it can be done in one place, it can surely be done in their place as well.
That kind of brings me to another question that I had written down. I know that the role of culture plays, well, a huge role in any sort of patient safety environment, and a lot of people attribute that to the way that systems are set up. Is there any quick win for all systems in spite of the context that people could implement? Or any quick wins to be had at all?
Well, it's not a quick win, but I do think if you are a hospital, and I'm referring to hospitals because there is relatively little known about safety in primary care and the community, and we're working on that, but just using it as an illustration, because most people will be trying to think what they can do in their hospital. So just a prelude to answering your question. If a hospital has an above average level of healthcare infection, it cannot call itself safe. It is an unsafe environment. And therefore, if you wanted to set yourself an initial challenge, it would be to achieve the lowest, amongst the lowest levels of healthcare infection in the world. And that is both difficult and straightforward. It's straightforward because the evidence as to how you do it is easy. It's all clear and obvious. The difficulty is that it requires major cultural and behavioral change on the part of the staff. And that is the challenge of a modern manager in healthcare. If she or he cannot change the culture, engage their staff, getting them passionate and enthusiastic about safety, then they should be kicked out with a boot up their backside.
Well, I know you mentioned in your presentation that Dr. Pronobos has done all of his great work on infection, and a lot of that was around that culture change. Are there any other examples that come to mind of people who have done this well? Where should people be looking?
Well, I think the Cleveland Clinic stands out, particularly in the way they focused their attention on the patient's experience of quality. They moved themselves up the league table They're a brilliant example. The Dana-Farber Cancer Institute in Boston, who are involved in the death of the Boston Globe health reporter Betsy Lehman by overdosing her with cancer chemotherapy and killing her, they took that as a transformational event, and they are now amongst the best in the world in embedding patients and family members right through their system. The strange thing, as I look around I've been looking around the world over the years, how some institutions are transformed by a single tragedy and others are not. They respond conscientiously initially, but they don't drive the organization with the memory of that tragedy in mind. Some do and some don't, and perhaps it says something again about the quality of leadership and the culture. Some prefer to forget. What was the Hotel California? Some dance to remember, some dance to forget.
Well, we've also had another question come in from the audience. What should we do about individual medics that undermine safety systems?
Well, I think it's a two-stage process. One is to encourage them, bring about peer pressure. And then if that doesn't work, then I think there comes a time when if the organization's really serious about safety and you have a surgeon who won't cooperate in the checklist, then perhaps to invite them to go and work somewhere where there's an unsafe culture and they would belong there.
Well, I realize we're getting close to time, so I will do a final call for questions from the audience, but also one more question for you. If you had just a single message that you wanted people to walk away from this presentation with, what would it be?
The single message would be instill passion for safety and quality improvement in your frontline staff.
Well, I can't think of a better note to end on than that. But we wanted to thank you so much for joining us today. This was very insightful and very much enjoyed it. And thank you to all of you for joining. And please feel free to shoot any questions that you might have to the LHSN email address, which is lhsn@imperial.ac.uk. Thank you so much.